Welcome again to our attendees as well as our panelists for today's session that's part of ASTARISQ, or Addressing Structural Racism to Improve Safety, Quality, and Trustworthiness in Health Delivery Systems. I'm so pleased to have movers and shakers within the MedStar Health system with us today to talk about how they've integrated health equity frameworks into their implementation for improving and ensuring patient safety across its health system. Without further ado, let me get into a couple of housekeeping issues before we get started. So this meeting is being recorded. I encourage our panelists and attendees to use the chat as we continue to talk about these issues of addressing structural racism in health delivery systems. Also, please feel free to use the Q&A button at the bottom of your screen to submit questions to our panelists. We have a series of round robin questions for our panelists today, but certainly we're leaving time towards the end of today's discussion for our Q&A with our attendees. So without, again, further ado, I'd like to introduce our panel. And I think it's always important for our panelists to be able to introduce themselves. So I'm going to do my Hollywood squares. And at the top of my Hollywood squares, I see Carrie. Carrie, do you mind introducing yourself and share one goal that you have for participating in today's conversation?
No problem. So good afternoon. My name is Carrie Sutton. I'm the Scientific Director for Health Equity Research at the MedStar Health Research Institute. My main goal is to continue to have these wonderful conversations about advancing health equity via patient safety and being able to collaborate on these discussions.
Thanks, Carrie. Laura, do you mind going?
Absolutely. Hi, Laura Lee. I'm the Assistant Vice President for Patient Safety at MedStar Health. I'm a nurse by training, but have spent basically my whole career doing patient safety. My goal for today is to build community around how to operationalize these sometimes very theoretical and big issues so that we can actually take it to the bedside with our providers and our patients.
Thanks, Laura. Angela?
All right, thank you so much for having us. I am Angela Thomas, Vice President for Healthcare Delivery Research at MedStar Health Research Institute, also the Executive Lead for our DC Safe Baby, Safe Moms initiative as well. I am this weird, funky blend between operations and science. And my goal for the conversation is to reflect as well as share our journey for intersecting patient safety and health equity.
Thanks, Angela. Kate.
Hi, everyone. I'm Kate Kellogg. I'm the Vice President for Patient Safety and Infection Prevention for the MedStar system. And like Laura, I'm really hoping that this serves to help us connect with more folks that are doing this work. And there's such a need for us to get together and connect and learn from one another. And so I'm hoping this will really spark some more conversation and connections in this area.
Excellent. And certainly one of the things that I love about this series is this community of practice that we're developing, not only sharing the promising practices, whether that's at MedStar or happening in community-based organizations, but again, improving health equity overall. So, you know, whoever wants to go first, who can share the origin story of MedStar's health equity initiative?
Well, I will kick it off. I've been nominated to kick off that conversation. Having shared this the other day and it felt really long, I'll give a really Cliff's Notes version. So at least my experience for our health equity journey, I would say started in 2013. I've been with MedStar Health since 2008. And 2013 had just became the administrative director for our healthcare delivery research program, then health services research. And MedStar Health was wanting to put that on our strategic plan. Long story short, we formed an internal advisory board about our priorities we should have. And Christopher King, who's now the dean of the School of Health, raised his hand and said, we should focus on health equity. Me and him knew what that meant, but everybody else around the table, not so much. And so we started, at least from the Research Institute's perspective, engaging a consultant who now is really near and dear to our heart and serves as a community member on a number of our health equity initiatives for the system. But we started with her trying to figure out what that looks like with the Research Institute. Along the way, I personally decided to get my doctoral degree, and as our organization was on a patient safety journey, a high reliability journey, et cetera, thought it would be cool just to look at this intersection between health equity and patient safety. And then our friend Kate, who's on the call, was one of our great researchers as well. I remember working with her and some others with the patient safety team, looking at this through an equity lens, and realized it wasn't as easy as we hoped it would be. And also realized some findings that we didn't think we would find. And so hence began the patient safety and health equity journey specifically. But as we began to build the healthcare delivery research's health equity journey, we established a Center for Health Equity Research along the way, had an inaugural scientific director, had a project we were doing with the AAMC along the way where I met Carrie, the lovely face on this call. And ultimately, when we needed a new director, convinced her to come to MedStar Health. Along the way, with the pandemic and with also the murder of George Floyd and some other things, and just a heart for health equity overall, we use a lot of those learnings in that journey as we begin to think about our equity, inclusion, and diversity initiative at MedStar Health. And MedStar Health actually bakes in health equity within that particular umbrella with a dual report to quality and safety. So it was with that that we established some action teams. We established some conversations about what this looks like. And now we have health equity at our system level, actual board on a committee from our board of directors focused specifically on health equity, as well as an AVP for health equity, who's also a former researcher with the MedStar Health Research Institute. And that reports directly to our Vice President for Equity, Inclusion, and Diversity, as well as to our Chief Quality and Safety Officer. And so we're really proud of our journey, but we still have a lot of work to do. And so I love that our goals are to share and to connect, because that's what it's going to take to do this work well nationally.
Absolutely. Thank you for sharing not only the origin story, but how you've continued to grow and advance this work across the system, as well within each of your individual units. Laura, Kate, Carrie, anything you want to add about your own journeys in navigating this at MedStar?
I think I'll just add that, Angela outlined that this work really started in the Research Institute, which is so neat, and then really said, okay, this has got to be operationalized. And concurrently with the Research Institute saying this is a really important priority and we need to be putting resources and time and attention here, the organization was saying the same thing. And so that became a really nice way to bring those pieces together. And sometimes I think sort of research can be really siloed from the overall organizational goals, or it's harder to see direct connections maybe sometimes and to find direct connection points. And this was one that really worked well for everyone to say, hey, these guys have started some really amazing work, and like we should be using what we know already and starting to apply it. And that was such a great opportunity for the organization to capitalize on the work that was already being done and say, what else needs to be done? And how could we prioritize this work and the future of it as an organizational priority? And so I think the sort of leadership, engagement, and investment in that was so key to catalyzing the work from the really early days.
And I think that having local data, really solid data, tells a really compelling story, because you see national data and it's almost like, well, maybe that's not us. But I was not here when all the research was done, but what this amazing team has done is really said, look, we have an issue at MedStar Health and we have to fix it. And it just, I think, really sort of jump-started and pushed along the efforts because we had that good solid data.
Excellent. And I think we have a couple questions later about data, but sort of relatedly, let's talk about patient safety. So how does health equity influence patient safety, and why is that important for health systems to keep in mind?
Well, Hillary, it's such an important question, and it's one that we've been really excited to start to really dive into thinking about. And I know, patient safety at a national level through our big organizations like IHI, really starting to look at health equity and say, this is not a separate issue from patient safety. It's really the same. And we need to figure out how these things, we need to bring things together in patient safety to not just say, oh, health equity is about, patient outcomes or whatever it is, but it directly impacts patient safety. And that can be really hard for people to wrap their minds around and accept in a way, in sort of a non-defensive way. Because I think a lot of times in patient safety, one of our underlying things is everybody's doing the best they can at any given moment. I'll talk in a second about kind of our MedStar Health approach to safety, but we're all doing the best we can with what we've got in the moment. And so we find that when we start to talk about health equity, sometimes people's sort of defensiveness can come up, and that can be a difficult thing for people to start to say, oh, health equity really is directly impacting patient safety, and we've got to look at that. And so I'll just back up a second and just say, MedStar Health, for those of you who don't know us in our patient safety work, so we have the National Center for Human Factors in Healthcare, which is the biggest integrated human factor center in healthcare in the country. And that's been in development at MedStar Health for about a decade now. And that it really grounds kind of our patient safety program operationally, again, relating to research, because that group does a lot of our patient safety research, but really sort of grounds us in safety science and human factors engineering in particular. And that really drives the lens through which we really look at our entire safety program. And so we have really, over the last decade, developed a really robust process for looking at events proactively and reactively that integrates safety science. And with that safety science approach, it's our goal to not look at, who screwed up and how, but what happened and why. And I think that foundation and that overall approach has set the stage really well for us to start to think about how to integrate thinking about health equity into patient safety, because we are always trying to take a system look. We are always trying to say, how are people kind of set up to get to this outcome? And are there systematic things that we can do to decrease the likelihood that anybody would end up, in the position where this outcome could happen? And so I think that's really the fact that that's what we teach, that's what we practice, has really it made it a lot easier, I think, for us, because we have been working on the cultural piece of patient safety being a system with a systems focus for a decade. And that has allowed us to, I think, a little bit more easily integrate the idea of looking at health equity in that same way, which I think has served to at least decrease some of that defensiveness that can happen with people when they feel like, oh my gosh, someone's coming in and telling me, I have biases or whatnot, and that made this thing happen. Because we focus so much on the systems approach and looking at events that way, I think that really helped set us up. So that's sort of my big picture. Laura, I'm sure you have other things to add.
Yeah, I agree. I think that the basis of our safety program, because it's so systems based and it's human factors driven and science based, it really helps. I just want to take one step back and just talk about harm a little bit. So, usually we think about physical harm when we think about patient safety, but we need to really expand that definition to include things like emotional harm, financial harm, intergenerational harm, if you've got an event that occurs with maybe a child, and how it impacts the rest of the family. So it's in that sort of big bucket that we need to start thinking about harm and how health equity and biases can influence that. As Kate said, we are humans. People are going to bring their personal biases to work. We're going to make mistakes every day. And we're starting now to look at those events through this health equity lens. And I'll just give you two examples of sort of we're rethinking why events occur. So we had a young woman who presented in one of our EDs with pretty classic signs and symptoms of preeclampsia. But because of just her sort of behavior and the fact that she was wearing socks that had marijuana leaves on them, the team completely anchored on substance abuse and not on her preeclampsia, and misdiagnosed the patient and significantly delayed care for her. So here's a group of people trying to do the right thing, but because of who they thought this person was, maybe implicit biases they brought in, care was delayed. Similar event, we had an EMT respond to a call in a community where there's a high incidence of substance abuse. When they arrived in the house, there was drug paraphernalia in the house and around the patient. The EMTs and the ED staff both anchored again on substance abuse and missed a really time-sensitive stroke diagnosis. So it was where this individual lived, the fact that there was drug paraphernalia in their house that really anchored these people. Also at play are sort of long-standing processes and practices that can introduce bias or facilitate harm. So one example, and most of the people on the call are probably familiar with it, the long-standing practice of using race as a factor when calculating EGFR. And that now has changed. We changed it at MedStar. But just examples of how our own personal biases, long-standing practices that were maybe based on evidence, but now certainly the evidence shows otherwise, can really impact harm and patient safety. Another example are medical devices where maybe skin tone can influence the accuracy, like with temporal thermometers. So as we start to look at these safety events, we're really trying to expand how we look at them. We have a process where we look at 6 contributing factors domains. And within each of those domains, we ask a series of questions. So it may be about communication or policies and procedures, culture, and leadership. So what we're starting to do now is to embed health equity inquiries into those interview questions. So for instance, when we're talking about communication and information management, we'll ask about literacy level or a person's psychological safety, or language barriers, nonverbal cues that might be cultural. For policies and procedures, I just mentioned the use of clinical algorithms that have a race as a factor. And so trying to look for those and get rid of those so that we don't end up misdiagnosing or miscaring for someone. Around leadership and culture, are we modeling by our leaders culture of humility, and are we giving resources so that our employees can really begin to think about and learn about health equity and bias so that they can start to be on the lookout for themselves. Human factors and influences, we talked about the implicit bias, we talked about the substance abuse, but socioeconomic status, things like that, race and ethnicity. And then physical environment. I mean, are we ADA compliant? Are we thinking about how the education level of our patients that we're sending home with equipment? All that, you can have implicit bias around all that, certainly impact care and patient safety. So those are just some examples of how we're trying to take existing processes that have been developed and are pretty much working, but also now embedding into them this health equity lens. So we're not really overlaying new processes. We're just bolstering up and enhancing the existing ones.
And I know
That's
Carrie
great. Thank you,
was going to
Laura and
add
Kate. Yeah. Mm-hmm.
to this as well, but I was just going to add, because a question popped up in the Q&A that I just wanted to tie in, answering to what you were just talking about, Laura, in terms of, and the question is, how do you put this into practice? These are good examples. How do you put them into practice? And that, I think, is one of the things that, as Laura's saying, that we're trying to do is integrate this lens into all of our event reviews, and then use this to help us develop system-focused solutions. So as you all well know, I'm sure, our goal in patient safety is to develop strong solutions which basically don't allow the thing that happened to happen again. So just like you can't start your microwave with the door open, it's impossible. You cannot make that error. We try to design systems where the thing that happened just simply isn't possible. So for the patient with the stroke, that was misdiagnosed as substance abuse? Could we put a process in place at triage where even, no matter what, if you have XYZ symptoms, you go straight back, or some kind of process that basically doesn't allow for bias in that potential bias there to influence the outcome. And that's just one, I just kind of made that up, but you sort of see where I'm going, which is if we put that lens into the event review, then it allows us to develop solutions that will, our goal is then to basically eliminate the potential impact of the implicit bias that we know that everyone has. Just like everyone has slips and lapses, we know it's going to happen. We know that we have to account for there being some implicit biases, despite the fact that we wish they weren't there and we're trying to help people understand them and eliminate them. We know that they're there. So how can we limit the impact on the patient at this time? And so integrating that lens and those questions into our event reviews, as Laura said, in all those categories, it allows us to gather that information and inform the solutions that we're developing to try to mitigate any harm from those potential impacts. And Carrie, I know you wanted to add some pieces here with patient safety and the community, I think, as well.
And I might actually cut in just because the chat has a lot of thoughts, and it's been so great to see both the Q&A and the chat go off. But one question, just to bring it back for a second before we dive in, is about the definition of health equity and diversity, because sometimes I think we take for granted that health equity is a term that we all know or we all care about, but what do we actually mean? So Carrie, I'm going to ask you, sort of from the research lens, how are you defining health equity, and how does that research then inform the practice and, again, the lens that is being used by practitioners within the health system?
Yeah, sure. So I define health equity as an operating definition that I've been using for years. It's about the fair and just opportunity for health, best health, and health care. And in order to have those fair and just opportunities, you must be able to remove those obstacles to those things, such as institutional policies, racism, power, things such as food insecurity, some of the social drivers to inequities. You're enabling and working with communities to ensure that they're able to have those opportunities for health and life and well-being, as we're using now, by working on those obstacles. And that's through research. That's through institutional policies, as we're talking about patient safety. That's also through strengthening multi-sector partners and partnerships that academic organizations do have with their community organizations and their patients. And so that's really how health equity is defined. I did see it said health equity and diversity. I would like to also be very clear that health equity is different than equity, diversity, inclusion. There are different practices, there are different strategies, and there are different methodologies. They do not operate under the same umbrella. However, they're very complementary in the same goals. You cannot have diversity without health equity. You cannot have health equity without diversity, equity, inclusion, and belonging. So just wanted to be clear on that.
Thanks, Carrie. Other thoughts, Angela?
Yeah, Carrie said it all, as she usually does. No, I think seriously, her drawing the distinction between equity, inclusion, and diversity and health equity, it really boils down, like when I have my own operating definition, it's just about fair and just opportunity for optimal health. And in all of what Carrie described goes into being able to achieve that. I will also underscore that we can't talk about high quality care without equitable care. And so any organization, and it should be any healthcare provider, should be striving for high quality care. And you just can't get there unless you're looking at care through an equity lens to determine, are you delivering equitable care?
Absolutely. Thanks, Angela. So a couple other questions in the chat that I think really speak to these examples that Laura and Kate have both provided already around how this is in practice. And so one of the questions was about the built environment. And so how does the role of facilities sort of influence patient safety and patient and provider safety during delivery?
Yeah, I love this question actually, because it's so important. We have so many poorly designed healthcare facilities just baseline in terms of being able to provide care, let alone from a patient's perspective. So I love this question because now I'm just about to dive into the literature as soon as I get off the call, because I don't have a specific answer for this. My colleagues may, but before you open a new building or launch a new procedure or a new process, we really encourage people to do what we call a proactive risk assessment. Some people call them failure modes and effects analysis, but where you take a process or you take an environment and you literally try to figure out everything that's the matter with it so that you have a chance to mitigate any risks from a harm standpoint or an efficiency effectiveness standpoint before you would open that building or launch that process. So I love this question because we're going to immediately go back and start talking to folks about when we design new space, it's not only about physical harm, it's about emotional harm and discriminatory harm. So I think partnering with our health equity specialists about this, with our facilities folks, our architects, our environmental folks, is so key. And so I love this question. I don't know if you guys have any more specific information.
Well, I was just going to add, Laura, to what you were saying, and it's another opportunity for those of you who work under the HRO, high reliability organization principles. This is another opportunity really for deference to expertise and making sure the right people are at the table to have the conversation. And I think this question, I also love this question. It's very thoughtful and I think brings up some really interesting ideas. And so, Laura, as you're saying, when we do a PRA and we're thinking about the space and how it functions, if we don't have the right folks if we're not asking the right questions, we're not going to get the right answers. And in the same way, we need the nurses to help us understand how they would work in the workflow. We need our patients, all different kinds of our patients, to help us understand. My brother is deaf and his needs in the space in a room are going to be different. And if nobody thinks of that and asks those questions, we're not going to know. So I think that's a really good opportunity to think in that way. And the more we can have folks just having this in their mind, I think we'll talk about this in a little bit, but for us, one of the biggest goals in the early parts of this journey has just been to get everyone on all of our teams just thinking about, could health equity have contributed in this case? Just starting with that awareness and asking questions. So it's a wonderful thing. And Angela, I see you off mute, so I'll turn it to you.
Yeah, no, I love this question as well. I just wanted to give an example, a real world example of how this looked at MedStar Health. So when we started our Safe Baby, Safe Moms initiative, and it is about this deference to expertise principle that Kate just underscored. We, at least from my seat, a non-clinician seat, didn't realize that there are a number of different locations within the hospital where patients could receive prenatal care. And there, in this particular initiative, those who we were really wanting and needing to give this expanded thorough services to, they actually, most of them were receiving care in a clinic location that was in the basement with no windows, hard to find, near the elevator. And one of the clinicians said, if we're going to do this successfully, if one of our goals is to reduce disparities in maternal and child health outcomes, we've got to change this space. It's sending a message about the value of these particular patients. And so we've got to change it. And to the credit of the leadership of MedStar Health in that particular hospital, we found space in a very bright location and invested almost $1 million to renovate that space. And it was not covered by the grant. It was leadership buy-in to, yeah, this is an equity issue. Thank you for raising that. And now we have this beautiful space, and that was constructed in the middle of the pandemic. But that was the value of being able to look at something through an equity lens and consider the built environment so you can deliver high quality, equitable care.
I would also like to add to
Thank
that.
you.
Angela, thank you for that, because it underscores kind of our commitment at MedStar and our commitment of other organizations of really partnering with the community to understand the needs and making like actionable choices. And Hillary, you said something in the very beginning about the description of this particular learning about trustworthiness. And trustworthiness is really making sure that trust, earning trust, that onus is on the organization, the academic organization, and not the responsibility of our patients and our other communities. So therefore, making sure spaces are designed in appropriate manners, really partnering with patients, hearing their voices, really working in shared leadership models, that is a way in which we can deem ourselves worthy of the trust of our patients in order for us to advance health equity in all of our initiatives.
Absolutely. Thank you, Carrie. Thank you, Angela. So again, some really great questions in the chat. I encourage our attendees to continue to use the chat for maybe experiences that they've had within their own organizations, or if they have recommendations to others who are asking these questions. We certainly welcome the conversation. Carrie, you mentioned something about trustworthiness, which again is at the core of this series. But it's about building that trust, and the liability being on the institution and the providers, and that liability not being passed to the patient, the client, the user. So how has MedStar created that liability and accountability, right? I can imagine some people be like, well, I believe in this, but there's no way my VP will. So do you have advice, and this is to any of you, for like, what can be easy to change? What is still challenging? How do you get buy-in to prioritize these things and make the institution accountable and liable for health equity, rather than asking for the outsiders to do that work for us?
You bravely start. So one, I think data, and that in and of itself is a challenge. So I think in my kind of our journey, I briefly touched on that as to why we weren't able to answer some of the questions we thought we would be able to answer. Coloring that in a little bit more, we wanted to see if there were differences in patient safety events across all kinds of demographics: race, ethnicity, language, gender identity, sexuality, able-bodiedness, and the incarceration status, and the list goes on and on and on. And so when we went to look under the hood, we realized that we weren't collecting most of those measures. And those that we were collecting, there were a lot of either incomplete fields, unknowns, or inaccuracies. And then looking further under the hood, asking folks like registration personnel how they determined things like race and ethnicity, there was some work to improve, to say the least. And so even that exercise in and of itself was data, and getting folks to even be aware that, why don't we just look, and what does the data tell us? And guess what? We can't answer some questions because of the data. And then certain leaders wanted to answer those questions, or were, when you say that some registration people were just looking at patients to determine race and ethnicity, that data point gets people to listen. And so it's really trying to figure out these small spaces where you can win, small spaces where you can make a difference. And often data drives that. And so talking about the missingness of data, or the lack of integration between some systems, that was another thing. Our patient safety system didn't necessarily integrate with our EHR. And so is that a space? And so I would just say, take it small, but also listen to other leaders and what they care about. We were on a patient safety journey, and so our leaders cared about patient safety. And so being able to articulate with the data we did have that there were differences possibly in patient safety, that allowed people to have a conversation. And so listening, taking the data you have, don't wait for the perfect data, you will be waiting forever, but take the small steps, small wins in where your locus of control really is.
And I'll just add to that, and I think this is part of my answer whenever anyone asks how we get leadership engaged and to buy in. And one of my answers is always stories. Stories are so powerful, and it is one of the most straightforward ways that we can influence. And we all have those stories. And as we start to be able to imagine that as our mom, our best friend, our child, that immediately connects people to the issue that you're trying to help them understand. And so, I always say data and stories, those are the two places that we have it. And sometimes you have a little more of one or the other, depending on where you are. But those two things together are how we get people fired up to support what we know needs to happen. So I'll just add that because I think that helped as well for us to get a lot of this off the ground.
And I think it's obviously important to get leadership buy-in, but we've, at least in our experience, because we've trained all of our safety specialists in bias, and it's a great course. They all took it so they can start to think about it and recognize it. But what we found is that folks were incredibly hungry for this information. And it's inherently uncomfortable when you're sitting in a room and all of a sudden you're realizing that you have all these biases. But I have to say that to a person, they were grateful and wanted more information. So I think sort of getting a groundswell at the grassroots level, and if you can't get leadership buy-in, get enough momentum going at the grassroots that when people start talking about it, the leaders just simply can't ignore it then.
Sure. Thank you. And one question about training. So you mentioned that training of your staff, but how are employees, whether that's clinical staff, those who are at reception or administration, those who are doing patient provider care, how are they being trained in health equity, or what are the opportunities to help people have a more whole person healthcare approach and doing harm reduction, Laura, as you mentioned, outside of just the physical harm when they're receiving care at MedStar?
I can speak to what we're doing from a safety perspective, which is that we're training our safety specialists in, but I don't know if anybody has the overarching, there's a really good, it's called Recognizing Everyday Bias. It's a super class, very interactive, lots of sort of self-reflection and things like that. And my understanding is that it's going to be rolled out across MedStar over the next year or so. And it is an incredibly practical offering. And if Kate or Angela or Carrie have any more insight into that.
Yeah, there's already the annual modules around implicit bias, but the more robust training you mentioned, Laura, is supposed to be rolling out. I don't have a timeline on that. But I will say the registration staff, though,
Yes.
again, back to deference to expertise. So now you have data that says, hey, there could be some opportunity here for better collection of demographic data from our patients. But then asking the registration staff, what are the barriers you see to this? And just opening up that conversation, one was impactful to say, okay, now this makes sense. Let's now figure out ways to support them in the training and redesign training around that, because it's not easy asking patients about especially more sensitive demographic data. And so creating that safe space where registration staff were safe to speak up and say, you know what, I know it's important, but here's my challenge with that. And then being able to design training around that. So in the very beginning, when we were able to show that we had that issue, we engaged a small number of registration staff in that process to be able to design and pilot and then evaluate training from that. And so that was an important part in our journey.
Thanks, Angela. So we have a few questions still in our Q&A and in the chat, so certainly attendees feel free to add more. We have about 10 minutes for our Q&A. So similar to what you mentioned about involving the sort of registration staff in the development of sort of new policies, new practices, how have you involved patients in the planning process, strategic planning and policy development at MedStar?
Well,
Go ahead, Angela.
Go ahead, Angela, because
I
I think we're all waiting to go. We just don't.
So we all have, I think, a few different complementary lenses on this. So I'll just start with my own. So from our effort around when we were first starting to look at quality and safety and equity through an equity lens at MedStar Health, right out the gate, when we formed the task team or the committee, we engaged community members as part of that process. So, and that's a best practice you see a lot, especially in our health equity work, our equity, inclusion, and diversity work. Community is baked right into the same teams that are internal. We make sure we have community representation. So that's one critical way. In a number of our research projects, and Carrie can speak more to this, I'm sure, we have, especially when we're trying to tackle inequity issues or understand disparities, et cetera, we find ways to incorporate the patients either as partners, the community as partners, collaborators, et cetera. And so, in one particular project that we had where we really wanted to understand maternal safety, and all of us on this call are involved in that project, we purposefully elevated the voices of birthing individuals in that process. And a huge component of that particular project was both quantitative and qualitative ways to hear their voices, for them to share their experiences in their care delivery process and the whole perinatal journey. So there's just those kind of ways we try to be intentional in engaging community and also in patient.
And then
We also,
go ahead, Carrie.
Sorry.
No, go, Carrie.
Oh, no. I was just going to say, part of the Center for Health Equity Research, we do have a Community Leadership Council, and they did come up with their name. They did not want to be called a Community Advisory Board. They wanted to be called the CLC, Community Leadership Council, and we meet with them monthly. It has about 10 different organization leads from across the District of Columbia, Maryland, Virginia, not necessarily always connected to healthcare. We particularly chose multi-sector community organizations, and they are really helping with the strategy, and they advise the research direction for the Center for Health Equity Research. And they're also collaborators and investigators on many of the different projects that are happening across MHRI and also Georgetown. They're very vocal, and they wanted to be known to say that they're not a recruitment hub, that they wanted to be investigators and part of the process, and also be able to provide input and feedback and perspective on a lot of the research directions that are happening.
And I'll add from a safety perspective as well, that we really try to elevate the voices of our patients, particularly through, I'm gonna do air quotes on purpose, patient complaints. And I do that because we tend to call them that in healthcare, but actually we see them as a really great source of data. And we often find that through patient feedback mechanisms, we learn about safety concerns, often that have a health equity issue attached to them that need to be addressed. We had one of our transgender patients who had undergone surgery at one of our hospitals who had a really negative experience related to their gender and their surgery in one of our hospitals. And that came through the feedback mechanism, but ended up with us from a safety perspective because there was concern that the patient's care was not as robust and thorough, and the patient's outcomes could have been better had there not been perhaps bias involved in the case. And so I think also just realizing that there's a lot of different sources of data, and we have to elevate our patients' voices, how those come in. And sometimes in healthcare, we have a pretty traditional patriarchal top-down model, and it is not always the go-to to take those patients' voices and actually listen to them and elevate them. And so that's another thing that, obviously we're not perfect. And I'll just say, none of this are we doing perfectly, for sure, but it's one of the things we really try to be aware of and continue to work on and help all of our colleagues do as well.
Absolutely. Thank you, Kate. Thank you, Carrie. Actually, with that example that you just gave, we do have a question in the Q&A specifically about improving care for LGBTQ plus patients within health systems. The question is, are there specific policies or practices we can implement to achieve this across the care continuum, from trauma care to inpatient and outpatient settings, even within the same hospital system? So I don't know, Kate, if you have additional thoughts on that, or if Laura, Carrie, or Angela, other ideas to share.
Yeah, I think we can tie this back to the patient piece as well. I think this is a place where our patients help us immensely. And there's a lot of places where, we can ask our patients, what are the things that help you feel, included. So it's, if it's non-gendered bathrooms, if it's, it's, training for our staff, it's, pronouns being present in the EHR, so there's things I think that tend to come up frequently for our patients that we can standardize, even just the way we ask questions and, the way that things are phrased and framed. And we can actually facilitate that by phrasing it differently in the EHR, to trigger people to ask questions differently. And so I think that's a place where, obviously policies and procedures, help us on paper, but they often are sort of in the, proverbial filing cabinet of the digital world. But what are the tools that we can give to our folks at the front lines every day to really do those things that are meaningfully, change the experience of our patients?
I think part of that is making sure that we create this psychologically safe environment where it's okay to talk within our teams about these things, because you may witness it, but don't feel comfortable talking about it. So, you really have to deliberately and thoughtfully, like I said, develop this psychologically safe environment where people feel comfortable talking about it, bringing it up, and sort of working through it as a team.
Laura, I thank you for mentioning psychological safety, because that's something that's really foundational from a safety culture perspective, and also is really, I think, as you said, fundamental in this work as well, and will also help us, all of us, in when our patients give us feedback, which can be really hard when our patients say, hey, you didn't say that, doesn't sit well with me, and that doesn't hit right for me. And if we are used to being in a psychologically safe environment, that will also help us to create that for our patients, and to say, wow, I hear you, and I, absolutely, let me try to make that better and different. So I think that psychological safety being the baseline is valuable for our patients in so many ways.
Thanks, Laura. Thanks, Kate. So as we're getting to the end of our session, I want to take a moment to do a round robin on a call to action, right? We've asked a lot of you to share, again, the barriers that you've overcome, the challenges that remain ahead, as well as where you've been able to celebrate success. But what is one call to action that you have for our attendees in today's webinar? And I'm going to make, who do I want to pick on first? I'll pick on Angela first.
Felt it in my spirit you were going to do that, Hillary. I felt it. No, it is fine. I would say I usually, anytime I'm doing a talk about patient safety and health equity, my call to action is the same. It is speak up. It is, if you see something, say something. And that's whether or not you see actual harm being delivered, or you see something that should be changed in the system that could potentially be harmful or not be the best experience for our patients. And to the last question, yeah, I think that underscores the value of a workforce-based equity, inclusion, and diversity initiative. We've had a number of opportunities come where our associates have said, hey, I noticed there's not gender neutral bathrooms available for several floors in the hospital. We should probably change that, not just for our workforce, but also for our patients. And so it's the value of those different lenses being able to see. And so if you see something, whether you're directly impacted by it or not, somebody else could have already been or may be impacted in the future, and they need your voice because that's your locus of control where you have control over speaking up over something that you say. And so that's my call to action. See something, say something, speak up.
Laura?
Oh, yeah, sorry, there's a delay in the audio. Yeah, mine is collaboration. So we have got to do this as a healthcare industry together. None of us has it all right, and some of us are still struggling and doing things wrong, and we need to lean on one another. So there's a lot of people. We're doing some things at MedStar. There's folks all over the United States and the world that are doing this. And I thank you, Hillary, for having this group come together like this. It's huge, but we need to make this be 300 people in this room next time or next year, so we can do this together.
Absolutely. Would love. Let's get all 300 people.
Exactly.
Even for next week.
Everybody bring
Kate,
a friend.
Calls to action.
Did you say Kate or Carrie?
Kate.
Okay, great. Well, mine is related to Angela's, and it's don't wait for an invitation, or consider this your invitation. Welcome, you're invited. Come on down. You don't have to wait for a leadership dictate or a formal training to start to say, where are the areas in my work where I can start to look at this differently and think about health equity, and just start to reframe some of my everyday work. And all of us have opportunities to do that every single day. And if all of us start there, as we're working on bigger organizational and national changes that need to happen, we can all influence something every day, and just start there.
Thanks, Kate. Carrie.
Mine is simple. Mine is like, it's to get uncomfortable. These conversations are not easy. To speak up is not easy as a patient or as an expert, but it's going to require you to be in uncomfortable spaces and to be uncomfortable, and being able to challenge your own biases, your own positionality in these environments. And that is also very uncomfortable as well. So it's very simple, just to be uncomfortable, but to continue to push through.
Absolutely. What great words of wisdom and calls to action from our panelists today. And my call to action is to tell your friends about the ASTARISQ series. One of the things we always want to meet all of our attendees where they are. So our sessions are recorded and they will be posted to our YouTube channel, just as our sessions from last year, where you can see our amazing speakers like Angela speak from last year to this year. And we hope you also attend our final 3 sessions that happen again for the next 3 Wednesdays from 1 to 2 p.m. Eastern. Next week's is on overcoming systemic oppression and improving healthcare delivery. And it's really looking at how healthcare delivery can partner with community-based organizations, community leaders, and the patients that they serve to improve whole person care within policy coverage and clinical practice. So looking forward to seeing many of your faces next week and beyond. Again, I want to thank Laura, Angela, Kate, and Carrie for joining us for today's session, and looking forward to keeping the conversation going. Have a great rest of your week, everyone. And again, thanks for joining us for ASTARISQ today.